Dear friends and colleagues, it has been a privilege to have this opportunity in connecting with you through this medium. Today I will be reviewing and providing a brief overview on the recent advances and in the lymphomas and its management strategies. Lymphomas in general are defined as a group of malignant neoplasms originating from the lymph nodes or the lymphatic tissues, including tonsils, spleen, bone marrow, etc. Rarely they can disseminate from the lymphatics to some of the organs like brain, bone and even stomach, thereby producing what is called as this primary CNS lymphoma, etc. Basically, they are malignant tumors of the immune system and they are usually broadly divided into Hodgkin's and non-Hodgkin's lymphomas, and they are both considered as two different entities with unique etiopathogenesis and treatment modalities. Coming to the epidemiology, the incidence of lymphoma in our country is between 0.85 to 1.34 per 100,000 population, and this incidence is considered to be lower than that in the West and some countries like Japan, where the incidence is much higher. Also, the disease usually occurs in our country between the age of 20 to 40 years in up to 50% of the patient population, and this is considered as the disease of the young. Incidence of Hodgkin's again is considered to be lower in our country compared to the West, and the non-Hodgkin's lymphoma constitutes around 90% of the lymphomas that we see. But there are some lymphomas like follicular lymphomas which are usually high predilection in particular age group like elderly and above 65, whereas some others like Burkitt's lymphoma and lymphoblastic lymphomas which are typically considered as lymphomas in the pediatric population. Interestingly, Hodgkin's lymphoma have a bimodal presentation, that is, there is a peak in the young as well as in an elderly population. Now, as far as etiology of the lymphomas is concerned, it is usually multifactorial, including viral and immunodeficiency being considered as the usual factors. Typically, Epstein-Barr virus is considered as a causative factor for endemic Burkitt's lymphoma, and even in Hodgkin's lymphoma we have high antibody titer against Epstein-Barr, suggesting the same etiology. Another example is Helicobacter pylori, which is actually a causative agent for maltomas which happen in the stomach. Also, some immunodeficiency states like HIV can produce what is called as AIDS defining lymphomas like primary CNS lymphoma, which typically occurs when the CD4 count is low, usually less than 100. Again, in solid organ transplantation like renal transplantation and hepatic transplantation, when they are on immunosuppressive drugs, they are more prone to lymphomas and thereby the entity of post-transplantation lymphoma. So, usually immunodeficiency and viral etiogenesis are the commonest etiology attributed to lymphomas. Lymphomas are classified as per the latest 2016 revision of the WHO classification, and this classification is interesting because it takes into account the clinical aggressiveness or the clinical way of presentation, the histopathology or the morphology of the tumor as we see under the microscope, whether it is diffuse or follicular or mantle type, and also it takes into account immunohistochemistry, which is very important in subclassifying lymphomas. Also, we have cytogenetics and molecular factors to classify the lymphomas in 2016. Most common NHL diagnosis will include diffuse large cell lymphoma, follicular lymphoma, mantle cell lymphoma, small cell lymphoma. By this we can see that it will be classified as whether the cell is large or small, or whether the nodal architecture is diffuse or follicular. All these factors are considered when we classify lymphomas. And it is very pertinent that we classify and subclassify lymphomas to the correct extent, so that the exact subtype of lymphoma that we are dealing with, either if it is Hodgkin's or it is non-Hodgkin's, is known, because we know the prognosis as well as the treatment strategies differ. So, for example, NHL or non-Hodgkin's lymphoma has almost 70 subtypes which we need to classify, and also in Hodgkin's we have the classical Hodgkin's and the other type which is called as the nodal lymphocyte predominant Hodgkin's lymphoma. Lymphomas present with variable signs and symptoms, and this will attribute to the causative organs like lymphadenopathy, or it can be due to the result of lymphadenopathy, for example in the abdomen, which can produce back pain or abdominal pain. B symptoms is typical, which include unexplained weight loss, unexplained fever with night sweats, which again is part of the staging of lymphomas, and ascertaining B symptoms helps us in better classifying patients as in the staging. Patient can also present with extranodal signs and symptoms like vomiting, raised ICP and other symptoms of seizures, for example in primary CNS lymphoma. So, thereby a lymphoma symptoms and symptomatology can be widely varied. The diagnostic and staging investigations will include an intact lymph node biopsy with immunohistochemistry and bone marrow aspiration and biopsy studies in most of the cases. Whole body PET scan has become the standard of care in majority of the lymphomas. We get a fair idea on involvement of the lymphoma on above and below the diaphragm, so that we can classify the lymphomas as per the WHO modified Ann Arbor classification, whether how much the lymph nodes are involved, whether it is above the diaphragm, below the diaphragm, or visceral organs like liver or bone marrow are involved. Based on this, we can have stage 1 to stage 4 and with A symptoms or B symptoms. Accurate staging, I would say, is very mandatory for us to actually prognosticate the patient as well as to help in more accurate treatment. Apart from staging, almost all lymphomas we have what is called as a risk stratification by looking at some of the prognostic factors like age, stage at presentation, performance status of the patient, whether extranodal involvement is there or not. All this is clubbed together to form a prognostic system called International Prognostic Index, which is used in diffuse large B-cell lymphomas and many other lymphomas. And with this strict classification, we will be able to classify lymphomas into low risk or high risk. And this is important because a low risk lymphoma, the results with short course chemotherapy is going to be as high as 90%, whereas in a high risk lymphoma we have to think differently, we have to act aggressively, and you may require prolonged treatment, but still the results can be around 30 to 40%. The treatment modalities as far as lymphoma is concerned include conventional cytotoxic chemotherapy, but in addition to that, in most of the lymphomas we have what is called as targeted therapy, which act against, for example, if it is rituximab, is a monoclonal antibody which is targeted against the CD20 antigen, and the combination of chemotherapy plus targeted therapy has become the standard of care in lymphomas like diffuse large B-cell lymphoma. Usually in lymphomas like aggressive lymphomas, we need to give aggressive chemotherapy plus this targeted therapy, and in indolent lymphomas usually the treatment is milder and less intensive. Either way, the achievement of remission is the goal in almost all the lymphomas, and this is usually documented by doing a whole body PET scan at the end of the treatment. Majority of the lymphomas with the current treatment strategies are highly curable, and the intent should be cure, and as I told, a PET scan at the end of treatment will document remission. In some lymphomas like follicular lymphomas, we are also looking at monoclonal antibodies being continued over the course of 2 years, called as maintenance strategy, thereby improving the control rates. Other novel strategies that include stem cell transplantation, the drug antibody conjugates like brentuximab, and more excitingly the immunotherapy like anti-PD-L1 antibody like nivolumab is in the pipeline, and it is already approved in relapsed and refractory lymphomas, and this makes it this difficult subset of relapsed patients also under the purview of cure in a significant number of our patients. In summary, recent advances in diagnostic and treatment strategies in lymphomas has made it one of the highly curable malignancies, and a new hope is there for our patients who is diagnosed as lymphoma in 2016. Many thanks for listening, and I hope you found this session useful. Thank you.